Welcome to our live audience and welcome to those of you who are joining us online for today's Evaluator training. We're delighted to have you. My name is Robert Simpson. I'm the Medical Director for the Professionals Health Program, and Kelly Jacobson, who is our Program Manager. And we'll be talking briefly this morning about some overview of our program and the training today. Just to remind folks, there is a sign-in sheet that's at the end of this hall, just right as you go out the door. I would also like to recognize Michelle Stika, who is our program or our care coordinator, and Jennifer Falconrath, who is the Bureau Manager over Behavioral Health and Pharmacy. Nice to have you here. Thank you for joining us. So today's training, we're going to go through a variety of things. First of all, we have no known disclosures or potential conflicts of interest in relation to this presentation today. So why this training? Well, healthcare professionals are a valuable resource that we can't afford to lose. And at the moment, we are losing a lot of healthcare professionals due to stress and strain related to COVID, and there is in the ongoing loss that's related to substance use disorder, which will be our focus today. Although there's a lot of talk about healthcare professionals being heroes, and indeed their acts are heroic, putting folks on a pedestal is a dangerous thing, because from pedestals there's only one way to go. And so we need to recognize that healthcare professionals are human beings and as such are susceptible to illnesses, including substance use disorder, just like the remainder of the population. Our community desperately needs evaluators who can perform forensic evaluations for healthcare professionals who are to be involved with the Utah Professionals Health Program, as well as the probationary disciplinary pathway. And we'll talk about some of the differences between those two. We also need treatment and therapy that is specifically guided towards safety-sensitive professions, including healthcare professionals. So why the training? This is our first step in developing evaluators and providers of treatment services as well for UPHP, and developing a list of providers who will likely be utilized by people who are in the disciplinary probationary pathway as well. Anyone can become an approved provider. We'll go through the qualifications a little bit later. And importantly, it takes a village. At the moment, we're sending people out of state, albeit virtually, for these evaluations and for treatment. We want to cultivate a network of people in our state who can provide these services so we can look after our healthcare professionals. So the training objectives, we want to provide an overview of the Utah Professionals Health Program and the differences between our program and the probationary disciplinary pathway. We want to give evaluators an understanding of the tools needed to provide useful and safe evaluations. And that includes understanding of the forensic nature of evaluations and the implication of a forensic evaluation as opposed to a clinical evaluation. We want to provide understanding of ASAM placement criteria for safety-sensitive populations, how to conduct collateral interviews of colleagues and other involved parties that are both discrete, but also recognize the inherent conflicts of interest that can exist in terms of people who may be financially dependent upon the person being evaluated, people who may have emotional responses to the person being evaluated. All of these are important to take into consideration. Factors to consider when determining safety to practice, Introduction to toxicology will also be covered today. We're going to present later some emerging best practices for working with healthcare professionals. We will also share strategies that can be implemented to make practice more clinician-friendly, and review the Evaluator toolkit, which is an online tool. So our schedule for this morning, we're going to chat briefly for the first hour. Then there will be toxicology by Dr. Barry Lubin, and then after lunch, a practical approach to the evaluation of safety-sensitive professionals by Dr. Scott Teitelbaum. Afternoon, we'll have emerging best practices in treating healthcare workers in psychotherapeutic and medical settings, and that's by Dr. Megan Cole. And finally, we'll review the Evaluator toolkit and wrap up this at 4:30. So thank you, and I will hand you over to Kelly Jacobson.
Can everyone hear me okay? I'm not used to talking in a microphone, so just want to thank everybody who's here today who took time out of their busy schedules to be here in person and online and later on demand. It's nice to talk to an audience. Last time we did a presentation, we were speaking to a computer screen, and that's, if you've done that, it's kind of difficult, so it's nice to have people to engage with. So this morning I'm just going to give an overview of our program and the changes that have occurred in our program over the past year. So we are the Utah Professionals Health Program, and we are a health program that's been created by DOPL to work with licensed healthcare professionals with substance use disorders. The program has been around since the 1990s. It was previously known as the Utah Recovery Assistance Program, or people often, URAP, or people would refer to it as diversion. But in March of 2020, new legislation was passed really giving birth to the Utah Professionals Health Program, and with that have come a lot of changes, which we'll sort of talk about over our conversation this morning. So just to tell you a little bit about our program, we are considered an alternative to public discipline. So licensees who have engaged in some sort of misconduct related to substance use may be able to participate in our program as an alternative to the public discipline process, which we'll talk about a little bit later. But also, one of the big changes to the new legislation is that licensees are able to self-report directly to our program and not have to go through the investigation process. And that change came about because what other PHPs, or physician health programs across the country, have found is licensees are more likely to reach out earlier before impairment is showing up in the workplace when there's not fear around, is my license going to be publicly disciplined? Am I going to lose my credentialing? Am I going to get reported to the National Practitioner Database? And so that's a huge change, is licensees being able to self-report directly. And that can even be after an incident has happened at work at any point. So we are a voluntary program. Folks have a choice whether they want to join our program or not. And we are confidential, meaning that participation in our program is not known to the public or the professional licensing boards, as long as professionals are compliant with the requirements of the program. And we don't offer treatment. Essentially what we do is identify resources relevant to the licensee. We refer them for evaluation and monitor their adherence to those recommendations, typically over a 5-year period. And so that's really the big reason why we're doing this training. Is I started my position a little over a year ago, and the first sort of dilemma or issue we encountered was really lacking referral options for our professionals to become evaluated. There's a lot of great treatment, a lot of great evaluations, but the forensic type of evaluation is really a whole different ballgame, because we're looking at, really someone's ability to practice their profession safely. And so we're hoping to sort of start that conversation today and cultivate those resources in our own community. Oh, okay, thanks, Beth. So really we have this interesting dual role where, Dr. Simpson and I and the rest of the staff are really passionate about what we do, and we really care about our participants. And we're always having to balance that concern and compassion with public safety. So, our main role is to protect public safety. So when we're in a position where we have to make a decision where maybe there's some competing interests, we always have to make decisions on the side of public safety. So that's always our anchor when we come back to when we're trying to make decisions with participants. In terms of the licenses we serve, this is one of the changes in the legislation. DOPL had to sort of decide, based on limited resources, which professions to allow in the program, and really narrowed it down to the professions where there's really the greatest risk to public safety and where folks would most likely have the highest access to controlled medications, that sort of thing. And so the licensees that we serve are physicians, MDs, and osteopaths, physician assistants, podiatrists, nurses and nurse practitioners, dentists and dental hygienists, pharmacists and pharmacy techs, and veterinarians. And so in order to be eligible, you actually have to be licensed in the state of Utah and working in the state of Utah. And to qualify for a program, so you have to be licensed in one of the professions and also meet the criteria for a substance use disorder. So we only monitor substance use disorders in our program. Programs like ours around the country it really varies from state to state, program to program, which professions are monitored, what conditions are monitored. But in our program, we only monitor substance use disorders. But that doesn't mean we can't be a resource for other issues and connect people to other services for evaluation or even treatment. So if you're working with a licensed healthcare professional who's struggling with disruptive behavior in the workplace or mental health issues, we certainly could be a resource to help guide you through that process. And really, the reason why evaluation is key and why we're holding this training is it's really the foundation of what determines eligibility in our program and determines monitoring. And so the evaluation is just really important, not only for our participants getting the help that they need, but for how we're going to work with them. There's a few things that might disqualify someone from participating in our program. And those are really if something's happened where a patient is harmed, and we kind of really defined that, which is really providing care below the expected standard of care that results in some sort of adverse consequence for the patient. If something like that occurs, that would disqualify somebody from our program, and they would likely end up on the public probation track. Or if there's issues related to sexual misconduct that haven't occurred in the context of a substance use disorder, so charges or anything around that may disqualify somebody. And if the licensee's license is currently being disciplined in another jurisdiction or in Utah, then that would also disqualify them. So I want to talk a little bit about the structure of our program, because that's also one of the changes that occurred with the legislation. The previous program operated in a committee model, so there was the URAP committee, and basically the committee would make recommendations about how to intervene with participants in cases of return to use. They would meet on a quarterly basis. Our model has changed to a case management model, so there's no longer a committee model, but rather participants are assigned a clinical coordinator. Michelle is the first one we were able to hire. She's been with us about 3 months. She's a master's level clinician. She's an LCSW, who's worked in the substance abuse, the addictions field for quite a few years. And so the benefit of that is that we can respond in immediate time to issues of return to use behavior. instead of waiting, for a couple of months for the committee to meet, which we know with substance use, we got to intervene quickly. It's a life-threatening disease, and so that's one of the big changes. So we've moved from a committee model to case management model. We do have accountability to 2 committees. One is our executive advisory committee, and that's made up of licensed professionals and other key stakeholders in the community. And that committee has really helps us to guide policy and procedure. And we've been meeting with our committee for about a year, and it's taken us about a year to write our new rules, and now we're working on policy. So that's sort of the role of the committee, and they've been a tremendous resource to us as we're trying to rebuild our program. The other committee that we have is a clinical advisory committee, and that committee is made up of experts in the field of addiction. I can't believe the incredible people we have on this committee. But really, the committee serves 2 purposes. They're there to help us walk through difficult cases and make decisions, clinical decisions. But the other big piece, which I think is really important, is their accountability for us. So the participants now have the ability, which we're still writing policy around this, and we'll be rolling it out soon. But participants now have options for a grievance process. So if they're unhappy with a decision or disagree with a decision that we've made around, them returning to work or whatever the issue is, they can take that grievance to the committee, and the committee will hear that grievance. So it's sort of an accountability for our program too, which is important, because one of our values that we'll get to is accountability. Accountability not only to participants but to ourselves. So I'm the program manager, and I'm full-time. I'm a licensed clinical social worker with a background in addiction treatment. And we also have Dr. Simpson, part-time. And I think most of you know him, so I won't get into his background. And then we have a full-time program support specialist who really helps our program run, and our full-time clinical coordinator. We're hoping to be able to hire another one at the end of the fiscal year. And then we also have, I think another thing to point out is we have membership with the Federation of State Physician Health Programs. It's a national body that really provides best practices for programs like ours around the country. And so as we're developing rule, policy, and procedure, we've really relied on these guidelines of how our model should work. And we'll talk more about that, because those of you who are really interested in either providing treatment for healthcare professionals or being an evaluator, you may want to consider becoming a member of this, because you will have access to the guidelines. The Federation is also working on a credentialing process where it is likely in the future any professional health programs that are referring to treatment and for evaluation will be accredited by the FSPHP, and we will also likely adopt that and only refer to those programs. So, but we'll talk more about that later. So just to talk a little bit about our vision, mission, and values. This is something our committee has worked on this last year too. And this is so small that I can barely read it. So really our vision is to have a community where healthcare professionals feel safe to immediately seek support and treatment for a substance use disorder. That's really our vision. And we hope to all work together and collaborate to make that vision possible. Our mission is that through advocacy, education, support, and accountability, we provide a compassionate safe harbor for healthcare professionals to promote their well-being and the public safety. And the values that we've established are compassion, public safety, respect, advocacy. One of the biggest roles of a physician's health program or a professional's health program is advocacy, advocating for the professional who's in recovery. And then I've talked about accountability, and that goes both ways. And consistency. I think this consistency value is really important, because I think that's one thing we've recognized this last year as we've been working with folks is really, how do you be individualized but also be consistent? And I imagine you guys run into those challenges all the time. It's a really difficult tightrope to walk. So Anyway, so how people can be referred to our program, there's several different pathways. Really, anyone can refer to our program. And you do that either through an email or a phone call. And the types of referrals that we accept, typically we have the licensee who is self-reporting, or we may have referrals that come through the investigations process, or we may get referrals from employers, colleagues, family members, friends, that sort of thing. So really anyone can make a referral. Just want to walk you briefly through the process that participants go through when they work with us. So once I receive a referral, however that comes to me, I reach out to the person and I just talk with them about the referral and why it was made. And if it seems like the person would be appropriate, then I schedule an intake session. And we're doing everything virtually right now. And so during that session, I'm really just doing a brief biopsychosocial history, gathering information to see if it seems like they would be appropriate. And what I'm also determining is, what type of evaluation this person would need, or if they need immediate treatment. So after I meet with them for the intake session, then I refer them out. A couple things that I might do is if they need an evaluation, I'm referring them out for that. Or if they need immediate treatment, someone calls me and says, I'm drinking every day, I can't stop, or I get sick, I'm referring them straight to detox and then treatment following. Sometimes people come to us and they've already started the treatment process. They've entered residential treatment on their own and they're in IOP or something. So in those cases, it's me gathering the records to determine, do we have what we need or we need to do an initial evaluation. So those are kind of the three things that could come out of that intake. And as I mentioned, really I'm trying to determine during that session whether someone's appropriate if they meet the eligibility criteria, what type of evaluation is needed. And the other part I didn't mention was, is there any immediate public safety concerns? Typically, if someone comes to me and they're in their active addiction, I will ask them to voluntarily refrain from practice. And that's just a private agreement between us and the program that they not practice until they're cleared to practice. And that's where that evaluation piece is so important, because I rely on that to say, is this person safe or not? But in the beginning, we're erring on the side of public safety. If someone's, has to drink every morning to get their, to make it through the day, they're not safe to practice their profession. That's not a public discipline. Again, it's a private agreement. And really, typically for our program, there's three questions that there's a lot more, but three main questions that we need answered when we're sending someone out for evaluation. It's really, does this person have a substance use disorder or some other kind of condition that is either impairing or potentially could impair their ability to practice safely? If they do have a substance use disorder, what treatment is recommended, what level of care? And then the third is really, is this person currently safe to practice their profession with reasonable skill and safety? And if not, what needs to happen for them to be able to practice safely? So when I'm referring people out, those are the three questions. So one thing I want to throw in is we're really trying to develop an approved list for our program that we're going to pilot. But what I can tell you is the rest of the division also needs quality evaluations. We introduced Jennifer before. She's over the mental health professions and the pharmacists. And so they have other types of issues that they monitor on public probation, sexual boundary types of issues. And so the question you might get from them, from one of, if she refers to evaluation, is, does this person have a mental health issue that's disrupting their ability, to practice safely, those kinds of things. So we'll get into that stuff a little bit more. But for the purposes of our program, we work with folks with substance use disorders. So by rule, what governs our program is statute and rule. And in rule, the type of evaluation that we need is defined as a comprehensive clinical evaluation. And it's defined as an independent, as an evaluation by a division-approved independent evaluator that's diagnostically rigorous, forensic in nature, tailored to the specific needs of the participant, includes collateral information, and assesses the presence of a substance use disorder and of any other conditions that may affect the participant's physical or psychological fitness for practice. So by rule, that's the definition. And really, when I'm making a referral, when I'm sending someone out for evaluation, I'm looking at their individual circumstances, their needs. So really, what's their drug of choice? What substances are they using? Are there any psychiatric issues? Profession will largely determine who I'm referring them to. For example, physicians really need to be evaluated by other physicians. And so making those kinds of decisions. If there's any sexual boundary issues, connecting with an evaluator who's able to evaluate those things specifically, and just any other issues that require specific expertise. So, and then also if it's determined to refer directly to treatment, really looking at the acuity of the situation. Does the person have any income? I can tell you, the impact of COVID on our nurses this last year has been, well, I think you all know, it's been really hard. And so we've had a lot of folks come to us who've just lost their job. They don't have insurance benefits. Their whole life is just devastated. And so in some of those cases, I'm really just trying to get them connected to care quickly with what they can afford and those sorts of things. So this diagram just kind of gives you an idea of we have sort of a two-part intake process. Once the evaluation is completed, if there's no substance use disorder, then we don't bring him into the program. If residential treatment is recommended, then typically we have that person engage in the treatment, and then as they're discharging from residential treatment, we offer them the monitoring contract and begin monitoring at that point. If someone's recommended to do outpatient treatment, we typically start monitoring them and coordinate with their treatment provider around monitoring issues. And then sometimes that initial evaluation will recommend more evaluation, so that's another outcome that could happen. Once we get the evaluation back, we review that evaluation as a team and make decisions about what treatment, where they should go for treatment, that sort of thing, and then offer the agreement. And I'm going to turn it over to Dr. Simpson now to talk about monitoring.
Thanks, Kelly.
Yep.
So our contract is typically 5 years in length. There is an agreement to complete abstinence while in our program. There are meetings with the clinical coordinator that are monthly. The agreement to participate in random toxicology, and then participation in treatment and continuing care that's recommended from the evaluation. In order to participate, it's important for there to be a willingness to refrain from practice. So when somebody makes contact with us, until the evaluation is complete and a determination of safety to practice is made, people are asked to refrain from practice. Willingness to apply with practice accommodations, which may include restriction of access to controlled substances, use of medication-assisted treatment, particularly naltrexone, either in the oral or extended release form, and buprenorphine. Attendance at abstinence-based self-help or professionals in recovery groups, and having a worksite monitor. So sort of the timeline, the initial stabilization and withdrawal from management, followed by high-intensity treatment. The gray area, I hope that shows on the online, the initial intensity of monitoring over the first 2 years, and then a gradual reduction in the intensity of monitoring over the second through 5th years. And our hope is that initially people present and are resistant to the process and then become compliant with the process. And our goal is to move from compliance to really internalization of recovery principles and developing a process of recovery that is sustainable after completion of our program. Understanding the differences between us and the probationary process, again, quality evaluations are needed for healthcare professionals participating in both of those. UPHP will be developing this evaluator list that will be utilized by both pathways. So to compare and contrast, as Kelly has referred to, the UPHP participation is non-disciplinary, there is a safe harbor, there is confidentiality, participants are not known to the public or to their boards. In contrast, on public probation, it is a disciplinary public process in which participants are known not only to the public but to their respective boards. In UPHP, this is an important distinction. There is no entry into the National Practitioner Data Bank, whereas in the disciplinary process there is entry into the National Practitioner Data Bank. And that data bank, if there is an entry there, often will be Medicaid and Medicare services will exclude participant or people with National Data Bank entries from being paneled with Medicaid, Medicare. That is sort of the first domino to fall. Other insurers will then take providers off their panels. It is also very difficult to get credentialed with hospitals if you have National Practitioner Data Bank entries, and so it becomes extremely difficult to make a living. And then finally, as Kelly discussed already, we have a case management model which is able to respond really very much in real time, whereas the compliance model with a compliance manager often or can take a much longer period of time to respond to somebody who is in crisis or developing crisis. Do these programs work? Yes, they do. This is a study from 2009 in which 904 docs were studied who entered consecutively into 16 state physician health programs. They were studied for 5 years or longer. The programs were very similar to ours in that they were abstinence-based and required participants to participate in urine toxicology and other forms of toxicology for a period lasting at least 5 years. And after the 5-year period, 78% of participants had no positive toxicology results. And at post-treatment follow-up, 72% of these participants were still practicing. So this was the beginning of this idea that there is a new approach featuring long-term intensive monitoring that has incredibly good outcomes compared to treatment outcomes in the community. There is no such study across states for nurses, but there are a number of states that have conducted studies that show similar results. Those that instituted professional health programs that involve nurses consistently showed an increase in nurses seeking help for substance use disorders. This was a study from Pennsylvania in which there was a 75% increase in BHP or alternative to discipline programs over about an 18-month period, and a contemporaneous decrease, 40% of those participating in probationary programs, and importantly, at a year, a much higher percentage of those in alternative to discipline programs were engaged in nursing than those who were in disciplinary programs. So the magnitude of the problem in terms of nurses is immense just based on the sheer number of licenses, and we'll get back to that in a minute. Another important variable is the time to engage somebody in treatment. So the time from first contact with somebody with a substance use disorder to engaging them in a program. With people engaging with PHPs, the average time to having them enrolled in the program is less than 3 months. Alternatively, for those people who are engaged with disciplinary programs, the period between first contact and enrollment in the program is on average between 9 and 24 months. And that window is a dangerous window, right? Because if somebody's still in practice, then public safety is jeopardized. If somebody's lost their job and is no longer in practice, then they're sitting alone, worried, with all kinds of information coming at them from boards, from police departments, from hospitals, from insurers, and life is imploding, and they're not engaged in any kind of supportive program. So we want to narrow that window as much as possible. So in terms of the actual numbers and the magnitude of the problem, this slide demonstrates the number of active licenses, which docs account for about 12,000 licenses. Nurses, on the other hand, account for 36,000 licenses in the state of Utah. Pharmacists, 4,000, and notably, we don't have here dentists, podiatrists, veterinarians, physician assistants, all of whom we monitor. But if we add up the number of licenses, that's approximately 55,000 licenses in Utah. So how many people would we expect to have to meet criteria for a substance use disorder at any given time in Utah? Well, it turns out if you take the lifetime prevalence and do some statistical gymnastics, you come up with a point prevalence that is roughly 1% of the number of total licenses. So we would anticipate that at any given time in Utah, there are about 550 people with a medical license who have a substance use disorder. So a huge number of people. Here is our annual new enrollments by year, going back to 2011. And you can see that there was a peak in 2012, and then for a variety of reasons, there was drop-off. In 2022 already, I'm going to point out here to 2022, and that may not be visible on the WebEx, but we've already had 24 new cases, and we have another 10 cases or so already in development. So we're showing growth. I think some of that is because, well, I hope some of that is because people are hearing that there is a way that they can report confidentially, that there is a private pathway, but I think this also reflects the increased stress of life during COVID. So how to become an evaluator? Complete the training. You're already here. Terrific. We're delighted. Complete an application and submit that, and we'll go through that process on the online toolkit, and we'll review that a little later on.
No, a mistake in that slide. I think we said 2022 and it's 2021, obviously.
Yes, of course it is.
That was my mistake. Oops, okay. All right. Is our break at, I forgot what break time how long we have? 9:45. Okay, so we have a little bit of time. Okay. So we have created a toolkit for folks who are interested in becoming an approved evaluator. So I'm just going to spend the rest of the time this morning walking through that toolkit. Let's see. That's not coming up on the slide, so let me try that again. My plan may be foiled. Okay. Can I ask a tech question really quick? If I have this hyperlink to website, does it not project, or do I have to, what do I have to do?
Oh, so you just want to show what's on this screen?
Uh-huh.
We just need to mirror your screens instead of extend
Ah, thank you so much. So this toolkit can be found on our website at uphp.utah.gov. At the top of our website, there's a link to the Evaluator toolkit. So just going to kind of walk through the table of contents and point your direction to some things that might be useful to you. Really, we just have an introduction. We talk about the process, which we've reviewed today, of how people come into the program, the definition of the comprehensive clinical evaluation, and the purpose of it, which we've already talked about this morning. But the first thing I wanted to talk about today is really sort of the requirements that we're looking at for evaluators to become approved. And these guidelines that are represented here come from guidelines created by the FSPHP, the Federation of State and Physician Health Programs. So one thing that Robert already alluded to this morning is that really the key difference in the types of evaluations we would be asking you to do and clinical evaluations that you're probably already used to doing is that there's really no therapeutic relationship, that the evaluation is forensic in nature. And really, we're looking at the questions of, diagnoses, level of care, and is somebody currently safe to practice. So I don't really want to read all of these to you because you can read them, but there's just a few of them I want to point out. Is really becoming familiar with the State Physician Health Program guidelines, which you can either just purchase a copy online, I think it's $99, or if you become a member, you have access to that. That really just helps you understand the requirements of someone who's participating in a PHP and the requirements, the standards that they will be looking at in terms of credentialing evaluators and treatment programs. A couple of things that we would ask if you decide you want to pursue being an evaluator is that you disclose the full cost of the evaluation prior to scheduling it. So that's the participants know up front how much the evaluation will cost. And that you have the ability to perform the evaluation in a timely manner. And really, ideally, that would be within 7 days. And if you're not able to do that, referring them or declining the referral. And that you have the resources to conduct collateral interviews. The collateral interviews are really the key to these types of evaluations. Dr. Teitelbaum, later this afternoon, is really going to be taking a deep dive into this process of collateral interviewing, who you should be getting those interviews from, and some of the conflicts of interest that can arise out of those, deciding who to gather collateral information from. So we'll talk about that more in detail later. But also the ability to inform us once you meet with the person for the evaluation, at least within 24 hours, your preliminary sort of diagnosis ability, the person's ability to practice. There's a form on here which I'll point to you in a minute, but it could be the form, it could just be a quick email to say, hey, I met with Joe, he's not safe to practice, looking at IOP, but I got to get some more collateral information. It could be something as simple as that, just so we have some immediate feedback. And then we really would like to shoot for getting the entire evaluation back in 10 days. And I know that's a quick turnaround. And we can work with folks around that. But those are the sort of the goals that we're shooting for. I think one thing to be aware, which Dr. Teitelbaum will talk about a little bit more today, is that because these evaluations are forensic in nature, it's very much a possibility that you could get called to testify at an administrative hearing. Typically, those types of things will happen in our program if we're attempting to remove someone in the program. Participants have a right to appeal that decision, and so it may go to an administrative hearing, and you may be called to testify about something in your evaluation. And then I imagine on public probation, there's other times you might be called to testify. So just being aware that that's really the nature of a forensic evaluation. And then also having a willingness to decline to perform an evaluation if there's a conflict of interest. So if, for example, you're treating someone and they need an evaluation, you probably should not be doing that evaluation. That would be a conflict of interest. And so just being aware of those conflicts, and also a willingness to disclose to the participant if you're affiliated with treatment. So for example, many of the multi-day evaluation centers that we may send people to out of state also might perform treatment, and so it's really important to help them understand we're sending you here for evaluation, but that doesn't mean you have to complete the treatment there, nor should the evaluator be referring to their own treatment. And so those are kind of the basic sort of qualities that we would be looking at in an evaluator. In terms of qualifications, the types of licenses that would be required to perform one of these evaluations would be a physician, a licensed mental health professional, whether that's CMHCs or licensed clinical social workers, psychologists, APRNs, or physician assistants. For physicians who are interested in performing these evaluations, they really should be board certified. Be certified by a board of the American Board of Medical Specialties and have completed a residency program, accredited by Accreditation Council for Graduate Medical Education. Wow, that was a mouthful. Be board certified in addiction psychiatry or addiction medicine. And really need to carry your own malpractice insurance, have had training in ASAM criteria, and be able to provide proof of that training through a certificate or something else. And really, to do these types of evaluation, I think in order to be successful, having experience doing evaluations would be important. And then we would ask you, if you decide to apply, to provide a resume documenting your experience working in the substance use disorder field. So having that background working in the field too.
Can I ask a question?
Yeah, absolutely.
Is it just a hard line of not referring to the program that you work for? Like, what if you, upon evaluation, and you're honest about your bias, find like this candidate would actually be well suited for the treatment center I'm working at? Like, would you have a third-party evaluation take place, or is it just a hard line? Like, you refer to your own?
It's a hard line. Oh, yeah. So the question was if you're doing the evaluation referring to your own treatment, is that a hard yes or no? And my response to that is that's a hard no, because we always want to give, what you'll find as you're doing these evaluations is people might not like you very much by the end of the evaluation. And you can find yourself in a situation where you're accused of things like you're just making this recommendation because you offer this level of care and it's bogus. You're just trying to make money off of me. And that actually does happen, unfortunately. And so that's really the hard no, is we would be asking you only for level of care recommendation, and then we will make the referral. We will give them options. In every situation, whether it's referring them for evaluation, I like to give people 3 options if I have 3 options. The goal of this training is to have 3 options, at least to give. And same with treatment. So once we get that evaluation back and the level of care is, let's say, residential, giving them 3 options to choose. Usually I will give, like if the evaluator is a part of the treatment program, if it seems appropriate, I will probably give that as an option, but I'll give them others as well. So does that help answer your question? Yeah, okay. Would you add anything else to that, Robert or Beth?
Wanted to clarify, that you'll make a level of care recommendation.
Yeah,
And that the PHP will recommend where they go,
yep.
the options where they go.
Yeah, so just we're looking for level of care, and then we determine where they go, because that treatment center also has to be approved. We have to feel confident that that we have a working relationship, that we're going to get the information that we need, and that lots of questions.
Just to follow up real quick.
Uh-huh.
If they just determine themselves based on the interview, like, I actually think this program would be good and I want to go to that, refer back to you guys for the referral, or?
Yeah, yep, so just keep in your head, I'm only going to talk level of care. I'm not going to talk about my program. And then when we talk to them, if they say, hey, I really liked that place, I want to go there, absolutely, yeah. As long as it's approved, yeah. As long as it's approved, I'm still going to give them options, but ultimately, if they choose that's what they want to do, then that's fine. Question in the back?
Yeah, so is the evaluation and whatever level of treatment they are eventually referred to, is all of that private paid by the individual that needs the treatment? Are there insurance companies that cover any of this sort of thing, or?
It's a great question. So the question is, I think the question really is, are licensees obligated to pay for this themselves? Do insurance companies cover this? So the first answer is yes. The licensee is responsible for paying for the cost of evaluation and treatment. One thing we didn't mention before, which I think is important to point out, is we don't charge a monitoring fee. So participating in our program and our services are free. That's kind of unique. Many programs around the country charge a monitoring fee, and for physicians in particular, can be quite expensive, upwards $1,000 a month. And so this is a service that licensing fees cover, but they are responsible for the cost of their own treatment and evaluation. And because these are really forensic level evaluations, they're not covered by insurance. And the price of the evaluation, which I'm guessing is going to be a question coming up, you set your own price. We don't dictate that, but I can kind of tell you, I can give you some ideas of what someone might expect to pay. So really, there's sort of 2 types of evaluations. There are multi-day evaluations, and typically, not always, this might be where I send a physician or a dentist. Really, what this evaluation entails is not only the ASAM, the biopsychosocial, but there might be neurocognitive testing as a part of that. There's a medical examination. There's many components to this, lab tests, all sorts of things. And really, it depends on the profession. But typically, just to speak in generally, a physician will likely get this type of evaluation. Not always, but in many cases. So they'll go to a center that does this over a 3 to 5 day period. They stay in a hotel, then they come in and do their testing over a period of time, because some of the evaluations also include polygraph testing and so on and so forth. So one of those evaluations, you could expect to pay anywhere between $3,000 to $7,000 to $9,000. Does that seem right, Beth? Probably the minimum range would be about $3,000 for that. Other physician level evaluations that might, if we have someone we don't really think we need neurocognitive testing or further evaluation, we're really just looking at, and the other piece too is we have people coming to us who are like, hey, I have a problem, I need help, this is serious. Then we have other people who refer to us that are like, I don't know what they're talking about. I don't have a problem. I'm fine. You're the one with the problem. Those folks are going to go to the multi-day evaluation for sure, because we're really trying to rule out what the problem is. We don't know if it's a substance use disorder. I might get a call from an employer who says, hey, this person is showing up late to work all the time. They are late on their charting. Their behavior is really erratic. We don't know what's going on, but we're going to make them see you. So that's those folks I'm sending out to a place that can do a multi-day evaluation. And we have some here in Salt Lake that can do those as well. Those are going to be more costly because they're really trying to nail down what is going on. Is it a substance use disorder? Is it mental health? What's going on? Then we have sort of our master's level folks, or even some physicians who just do a more straightforward, comprehensive biopsychosocial assessment. Those seem to range in price between $300 all the way up to $2,000, depending on your level of licensure and how comprehensive. You know, a physician could probably charge more because they're able to do more evaluation from a medical standpoint in addition to psychosocial and ASAM. So it really just depends on how comprehensive the evaluation is, your licensure level, what are all the components. And when Dr. Teitelbaum speaks later this afternoon, he'll get into more how we determine what type of evaluation somebody would have. I would say, you know, we've had probably, 7 nurses in the last 2 months who've been referred to us for diverting medications. And in those ones, we're just trying, we want, you know, diagnosis, level of care, get them in treatment. And in most cases, you know, an LCSW or a CMHC could do those types of evaluations if you've got that background. Did that help answer your question? I feel like I went on a tangent. Does someone else had a question? Uh-huh.
You know, those multi-day evaluations are really, the multi-day evaluations are really multidisciplinary. You know, you have a psychiatrist, you have an addiction specialist, you have a psychologist, you have social workers, you have counselors. There are multiple levels of evaluation that are being done and documented, and the reports can be 25 pages long. So these are, you know, you're paying more, but you're getting a very multifaceted, comprehensive evaluation. And not everybody's going to be able to do that, and that's fine, but some people are definitely going to need that.
Thanks, Beth, for adding that on there. Was there any other, I think there was a question over here. Uh-huh.
Excuse me, it may be covered later this afternoon as to what kind of evaluation each individual needs. I was just wondering why only the physicians need to be board certified or trained in addiction medicine.
Yeah.
So, I mean, there is board certification for nurse practitioners, I don't know if there's for PAs in addiction medicine and psychiatry. I just am wondering, will we have a broad group of people that may not specialize in substance use disorder that can be evaluators, but if you're a physician, you have to be.
Yeah. So the question is, why do the physicians only have to be board certified? So, Robert, help me out here. So, well, I think in general, and I don't know this is the best answer, but and maybe Beth helped me out here too. But I think when we're talking about these multi-day evaluations, which is usually going to be done, like Beth said, they're multifaceted. You really need to have a background and be board certified, and you have to have that experience because you're evaluating another physician who's pretty smart and pretty savvy. And if you don't have a background in substance use or have been trained in it, I mean, I think most of you maybe could see that could be a problem. And I think with why we haven't required that of nurses, I don't have an answer to that other than maybe we didn't know. But really, for all the professions, you know, unless we're talking about physicians, is really, you do need to have a background in treating and evaluating healthcare professionals. Yeah. I think it would definitely be an advantage. So I think Yeah, but it's probably just because we didn't know that that was theirs, to be honest. So didn't know that was an option. But really, you need to just have the background and experience. So did that answer your question? Okay. All right. Okay. So, so we've kind of gone through the minimum requirements and really how to become an approved evaluator is to complete this training. We'll probably offer an annual booster for those who have decided they want to be evaluators to just talk about dilemmas, issues, talk about cases, and then complete an application and just submit it to me. So if we scroll down here, we have sample forms and templates. So I'll kind of walk you through those. So we have put together a sample template. You certainly wouldn't have to use this, but it does cover everything that we would want to see in a comprehensive evaluation. So there's a few things that I'm going to point out. Most of them are pretty common knowledge. If you've done a comprehensive substance abuse evaluation, we're really getting a comprehensive biopsychosocial with some additions. So I'll point out the areas to focus on. And the first area of the template is really considering adding a statement of confidentiality or a waiver of confidentiality. Oh, is that Dr. Lubin over there? Oh, hi. Hi. We're just wrapping up and we'll be ready for you soon. Have a seat, yeah. So because we've sort of talked about that these evaluations, there's no clinical relationships, it's important that you're giving informed consent to the participant when you're evaluating them, letting them know that this isn't a typical doctor-patient relationship or therapist-client relationship, that this is really to determine if someone's, if they have a problem, what they need, and if they're safe to practice. So we've given you some samples of waivers that you could add to your own template if you don't want to use this one. I'm not going to read through those, but just point them out to you. And then the rest of it is just typically what you would see in a comprehensive biopsychosocial. One thing I want to point out in terms of the background of information and identifying participant information is really thinking about this in the context of their licensing and profession. Are they being referred by the Utah Professionals Health Program or by public probation? Do they have any history? The questions you would want to ask is, your license ever been publicly disciplined? Have you ever had a letter of concern? Has anything ever happened with your license? Have you ever been reported, or do you have malpractice claims? So thinking about that history. If they're licensed in other states, or if they've ever been disciplined in other states, those are questions you'd want to be asking. And then, all of our evaluations, we require that you've gathered that collateral information. And again, Dr. Teitelbaum will be talking about that in more detail this afternoon. But really, you should be getting collateral information from us. If they're being referred by public probation, reaching out to that compliance manager, making sure you have a release and getting information about their compliance history or the issues that led them to be on public probation. One thing I'll say that's kind of a difference between both programs is in our program, folks aren't offered the monitoring agreement until after they've had the evaluation. So we get the evaluation and then we determine, okay, are they eligible? We give them a contract. It's kind of the opposite on public probation because the investigation process is what drives the stipulation and order. And so typically they'll have that stipulation and order and then be required to get an evaluation. So they should be able to give you a copy of that and you can see the facts and findings of why they're on public probation. So it's really important that you're asking for that and that you see that, find out who their compliance manager is, maybe even the bureau manager, and getting that collateral information. Would you add anything to that, Jennifer, that's different or?
Stipulation and order is negotiated, and so I would just recommend speaking to the bureau manager or investigations regarding the reason why they're on probation. And I also wanted to mention that there could be a third reason why a person is requesting an evaluation, and that's if their license has been disciplined, like suspended, revoked, or what else? I'm sorry, I'm drawing a blank. Yeah, surrendered. They may want to re-enter into the field, so they may need to get an evaluation to show they're fit to practice. Maybe they don't have a substance use disorder anymore, so that may be another reason why they're referred to you for an evaluation.
So I was on the medical board for 8 years, and one of the things to understand about stipulations, if you look at one, is that they have been filtered through several attorneys, both on the state side and on the participant side. And sometimes you're going, and why is this person being monitored? But that's because it's been negotiated down to the point that it is least damaging to the participant, usually because they've had a lawyer that's been very expensive or persistent or whatever. And so you may not get a lot of information from the stipulation sometimes, and you still would have to go to get collateral from people who will actually talk to you or can talk to you.
Thank you. Thanks for adding that information. Okay, so collateral information, which we'll take a deeper dive into later. And there's examples of how you could write that into your report in this template. You know, all of our, which again we'll talk about, and Dr. Lubin is here to talk to us about toxicology in a minute, but we require at minimum that all folks being referred for evaluation have hair testing, a PETH, which is a blood test that looks at alcohol over the last several weeks, and a urine drug screen. So those will be the three sort of baseline tests. There could be more depending on the drug of choice or their substance that they're reporting use of. We will do that testing, or if you have the ability to do your own, you would let us know on that application form. In most cases, we can do it, but if you do your own, that's okay too, but there'll be some sort of requirements about that. But there's got to be testing as a part of the evaluation, and that's got to be put into the report is the main thing I wanted to point out. But we'll get into testing more a little bit this afternoon. ASAM, there should be a summary of the ASAM and why, you know, the ratings on the dimensions and support for those ratings. In terms of diagnosis, it's really, really important that we have accurate diagnosis. One of my observations in reading reports is I think clinicians are sometimes afraid to give someone a diagnosis, but this is really critical for our program because eventually it could determine the length of how long we monitor someone, but we're really not in a place that we can do that until we get really comprehensive evaluations with accurate diagnosis. And we would really want you to justify the diagnostic criteria, listing out the criteria that they met. And again, we'll be going over that in more detail later, but those are things that if we don't see in the report, we may be coming back to you saying, hey, we need you to list out this criteria and justify how you came up with this diagnosis. The other piece that needs to be included in the evaluation that's maybe different from what you're used to doing is making a safety to practice statement. So there's kind of three statements that we're looking at, and again, Dr. Teitelbaum will be covering this in more detail later today. But really, you know, is this practitioner able to practice his or her profession with reasonable safety without monitoring? Or are they able to practice only with monitoring, or are they not able to practice currently safely at all? And again, Dr. Teitelbaum will talk about how you sort of make those determinations, but that piece is absolutely critical in our evaluations because, you know, that determines whether someone can go to work or not, when we can release them to work, that sort of thing. And then if you're determining that someone is not safe to practice, then really outlining what needs to happen for them to be safe to practice. Well, they need to complete day treatment and have 3 months of abstinence, as evidenced by monitoring and so on and so forth, and be taking Vivitrol, it could be stuff like that. So, and then the last part, which we've already sort of talked about, is the treatment recommendations. Really, we're only looking for a level of care, and not referring somebody. We will make the referral. Yeah, question in the back.
So you mentioned if someone, for example, comes as a self-report,
Uh-huh.
so they haven't had any interaction with their licensing board or whatever, but then the assessment determines that they are not safe to practice currently, is that still a voluntary process for them to stop practicing, or at that point, do they get reported to the licensing board and they have some sort of disciplinary action there, or how does that work if it's determined that they're not safe to practice?
That's a really good question. So the question is, if the evaluation determines that they're not safe to practice, is that private or public? Does that get reported to the board? So your determination that they're not safe to practice, basically, if we have not asked them to sign a voluntary agreement, private agreement to not practice, then we would ask them to do so. Where that would remain confidential unless the person just said, nope, not doing it. Then I would then have an obligation to report that to the division, that this person has been found not safe to practice. They're continuing to practice and they refuse to follow through with anything we're asking them to do, which does happen. So, good question. Let's see, where are we at on time? A couple more minutes. I'll just finish this and then maybe we'll take a break a few minutes early and then we'll be back for Dr. Lubin. So just other things on the template. There's some examples of monitoring considerations. So we would ask you to speak to things that we should consider during monitoring, like really there's someone who really doesn't have a lot of support. We require people to attend abstinence-based support groups, but speaking to that, or if you're recommending Vivitrol, or they have a sponsor, or that they do, that they have a trauma background and they would really benefit from EMDR, so those sorts of things. And then just a few things to point out is we ask that you not make any recommendations for the length of the contract, because that's sort of determined, our program already has those rules and how long that should be. And then also, if you have done an evaluation and you're recommending additional evaluation like psychological testing or something like that, and that won't be accomplished, we ask that you go ahead and complete your portion of the report and send it, and then we can do addendums afterwards. And then, we haven't run into this, but in putting together this training, we've consulted with a lot of programs around the country, and they've sort of given us here's the things we run into. So a couple of things is, other programs struggle with evaluators saying, well, Doppel needs a certain diagnosis or a certain thing for you to be in the program. And so we just ask that really, we don't require anything, to be, our program is voluntary. If someone has a substance use disorder and they're licensed, then they can be in our program, but we don't require any specific length of treatment or anything else. We are required to monitor treatment recommendations, so really those are your recommendations and not ours. So, okay, that is the template. And if we go back to the toolkit, we do have some examples of assessments. In example 1 is an example of a multi-day evaluation that's multidisciplinary, that has a physician, a psychiatrist, social workers, that sort of thing. So that's an example of one of those. And then the second example is one of just a physician who had done an evaluation. These are all fictitious people, but it gives you an example. We also have an example of not a great evaluation, which is unfortunately the kind we get a lot. And then return to work recommendations. And so part of what Dr. Teitelbaum will talk to you about is really identifying, what steps needs to happen for this person to return to work, because we do have a process once someone is taken out of practice or voluntary refrain, there are steps that have to happen for them to return, a return to work plan. And this is how you can sort of help guide us through that, because we'll rely on your recommendations. So that's a sample of that. I think this is probably a good place to stop and take a break, and at the end of the day, we'll kind of take all the information that you're getting from the other presenters and hopefully wrap it up in a way that makes sense, and really try to answer all your questions at the end. That's it. Let's take a 15-minute break. We'll come back at 10 o'clock, and Dr. Lubin is going to talk about testing.